Thank you.
So this is something that I did when I was a student, really, because I was a little bit confused between the sampling and randomization. We are moving from sampling. I think that was the topic from last week, to randomization. So just to make everything clear, so it doesn't mean that there is a relationship. Well, there is, but the bottom line of this slide is just to make everything clear about sampling and randomization. So basically, there are two types of sampling, and I think at this point, it should be clear for you. There is a probabilistic sampling and non-probabilistic sampling. We discussed last week the random probabilistic sampling, the systematic, and the stratified. That was the topic of the last week. And then there are no probabilistic sampling, which are important as well, because we are using a lot of this kind of sampling. And this is something that is kind of surprising, because when I was a student, I thought it was probabilistic, really, and they are not. The convenience sampling is non-probabilistic, and this is something that we do every day in clinical research, and it's not probabilistic. So that means that not everyone has the same probability of being included in the study, and it has a lot of connotations for the, especially for the external validity of the study. And it doesn't mean that the study is not well designed. Maybe the study has a great internal validity, but you have to keep in mind what type of sampling was done in order to infer your results to your patients or to your population. The convenience sampling is something that, as I say, is very common in clinical research, because it's so usual to just pick up the patient from your hospital, and you don't need to create another strategy to bring the patients to the study. There is a cluster sampling, which is basically randomization of groups. Basically, it could be, for example, randomizing hospitals for example, to evaluate a new strategy to, for example, to reduce the rate of infection in the hospital. So you just randomize, you don't randomize participants, you randomize groups. In this context, it would be hospitals, for example, randomized hospitals. And the snowball is another non-probabilistic sampling, in which case to just ask the patients to bring more patients to the study. But it depends on, not everyone has the same possibility, the same probability of being included in the study. So I just wanted to make it clear before moving to the randomization, because as Iada said, there are 4 types of randomization. The first one is the sample randomization. The next one is the block randomization by blocks, the stratified randomization, and the adaptive randomization. If you ask me which one is more common, I would say the block randomization, but it depends on the design. It depends on the research question and on a number of things, but I think the most common nowadays is the block randomization. And then the adaptive randomization, we don't really know much about that. You will have some readings this week about the adaptive randomization, but again, don't worry too much about the adaptive randomization, because it's not really used in many clinical trials. And the other thing is that if you go for adaptive randomization, you have to justify why didn't you go for sample or blocks or stratify. It's not a matter of that you like the adaptive randomization. There are indications, and there are obviously contraindications for that, but basically, if you go for that, you have to justify to the peer reviews why block randomization wasn't a good option for you. So you have to keep in mind that, okay? That being said, I think it's worth discussing the block randomization and the stratified randomization, which is what I'm going to do over the next minutes. Let me see here. So this is let me just 1 second here. Right. Okay. So yeah. So what you see here is just a simulation of a clinical trial with 20 participants. On the left side, you see the simple randomization. On the right side, you see the block randomization. So I say there are 20 participants here. So basically, they are going to be allocated in the case of the simple randomization. They're going to be completely allocated at random, completely at random. So what is the problem of this? What is the problem of the random simple randomization? That especially in such a small study with only 20 participants, you may come across with this situation in which only 6 patients are going to be allocated to the group B, and as much as 14 patients are going to be allocated to group A, only by a chance, only by the effect of the chance, right? So this is going to be a huge problem for your statistical analysis, because you only have 6 patients allocated in the group B, and that's going to be a big problem, because you don't have enough information about the other arm of the study. You have a lot of information of the group A, but not much information about the group B. It is difficult to analyze to make a statistical analysis in this case. So this is why this is the main downside of the simple randomization. Okay, so now moving to the block randomization. So you have here one block, right? One block, and you can do this for a very small study, just one block of 20. So what the block randomization does is that it guarantees that 10 patients are going to be allocated in group A and 10 patients are going to be allocated in group B. This is this is the main advantage of the block randomization. Okay, and this is why. So when you read a clinical trial, they say we recruit 30 participants, and then 15 participants were allocated to group A and 15 participants to group B. Do you think this was by a chance? No, I don't think it wasn't by chance. That was one block of 30. And this is the way to do this, okay? I'm not sure if this year we are playing with this. There is a website, or it's called randomization.com, and you can play with all of these things. I learned this from that website. And you can see that you go for 30 or even 40 patients for simple randomization, you can have uneven groups like this, but you go only for one block, so you can do this, right? Now, so what is the problem with this one block of 20? The problem with this is that, as I'm trying to depict here, for the first 10 patients, only by a chance, 8 out of 10 were allocated to group B, only by chance, right? Is it important? It depends on the design of your study. It depends on what are you looking for, right? If this is not important for you, if this is not important in the context of the research question, that's not a problem. But sometimes maybe it's important, because imagine that this is a very slow recruitment process, and let's say that in the first year you randomize and then the first for the first half of the study only 2 patients were allocated to group A. Is that a problem? That's the question. If this is a problem, so maybe one block of 20 is not your choice, is not your best option. So this is why you have blocks. You can actually, for the same study, you can do 5 blocks of 4, for example, right? So that means that the allocation of the participants are going to be more even in a way. Yeah. So as you can see here in this example, 5 blocks of 4. So that means that for the first half of the study, 5 patients are going to be allocated in group B, and 5 patients are allocated in group A, and it's kind of more even distribution of the patient. Is that clear?
Yes, Wilson. I just would like to add, maybe, I don't know if you agree with me, a real life example for a big problem in the first block of 20. If treatment area change by year, and if, as you said, if you had a low rate of recruitment and the standard treatment, for example, changed in, you were able to recruit this patient in 3 years, and in the middle, the standard treatment changed. So it will influence a lot your result. Another thing is if you are expecting adverse event in one group and not in the other, for safety concern, probably you will not be able to see them in the beginning, and you can offer more risk for more patients in the end. So I guess this could be two kind of problems that we see in the block of 20. Again, as Wilson said, this way you will have the same 10 and 10 in this in both groups, what is great. But the recruitment of only one group, and in the second part of the time of your project, the other group can influence the result in the end. So in general, it's more common, and you can see, for example, in this block randomization, as Wilson said, from 1 to 4, the participation, the subject 1 to 4 has the same size, the same amount of A and B. And so this is the characteristic when you plan a block randomization of 4 patients. In this 4 interval of subject, you have 2A and 2B, but you don't know the sequence, and this is important to prevent the knowing the prevent or keeping your allocation concealment. I guess that's another importance of block randomization. Do you agree, Wilson?
Definitely, Karla. Yes. And the other thing I forgot to mention is that it depends on the size of your study, because I'm talking here about 20 participants, but imagine that you have 200 or 2,000 participants. So the blocks are not necessary anymore, really, because the effect of the chance is much less common to see this problem in a clinical trial involving 200 patients because of the chance, because of the effect of chance. The problem really is with the small clinical trials. So I think you may understand why it's important to use blocks, when to use blocks, why it's important the block randomization, and what is the main disadvantage of the simple randomization. Sorry, just trying to...
Wilson, our student Laura has a question, interesting question. I guess I don't know if you explain also the importance of different block size for not blinded, for open label trials, to keep the allocation concealment and these things.
Yes, so the block size, it has to be a multiple of the number of groups, right? So you have three arms, so you have to choose either a block of 3 or block of 6 or block of 9 or block of 12, right? You have two arms in your study, so you have to choose block of 2, 4, 6, 8, and so forth. So regarding the size of the block, so as I said, the main advantage of the block randomization is to reduce the risk of imbalance, right? So here, so you have two groups. When you have two groups and you have a block size, you choose a block size of 2, so that means that there's only two options, A and B or B and E, right? What is the problem with this? That it's very easy to guess the next one, right? Because imagine that you have, let me go back to this. Imagine that you have the first patient is allocated to A, the second patient is allocated to B. So if it's a fixed size block of 2, so I know that the next patient is going to be B. So it's very easy to guess the next allocation, which is a problem, right? And this is why it's not used. It's not useful to guess to have a, and you will never see this block size of 2, right? And then what happens if you have two groups, as in many clinical trials, but you choose a block size of 4, so it's going to be more difficult to guess the next allocation because you have there is actually a way to predict how many possibilities are going to be. In this case, there are going to be 6 possibilities. So you are jumping from 2 possibilities to 6 possibilities only by increasing the block size of 4, right? I want you to understand this because a block size of 2 is AB and BA. There's absolutely no more choice. But if you have two groups, the same two groups, but a block size of 4, look. So you have ABIB, AABB, BBAA, BABA, BAAB, ABBA. It's going to be more difficult to guess the next, right? But it still is possible. I mean, if you are clever, you may guess the next allocation. And the problem is that you are going to ruin the study because if you especially for the last one, right? Because if you know that this is the first, the second, the third, the fourth, the fifth, the sixth one is going to be guessed, right? It's easy to guess if you know the rules, right? So if you know the allocation of these patients, that's going to be a problem because that may introduce a huge bias to your design, okay? And then same here, because there are 3 groups, it has to be a group size of 3 or group size of 3, or group size of 6 or any multiple of 3, right? In this example, there are 3 groups, A, B, and C, and there are 6 possibilities. You go for a block size of 3. So again, it's going to be a little bit more difficult, but still it's possible to guess the last allocations, right? And then what happens if you have 4 groups and you have a block size of 4? You have 24 possibilities. So it's going to be really, really, really difficult to guess this last one, right? So, but still, the problem is that it is still possible to guess the, I mean, you know how it works. You may guess this last allocation. And this is why, and you can see how complex is going to be this, because for 4 groups and block size of 4, there are 24 possibilities, different possibilities to be allocated of different blocks, right? But then I think this is a nice way to introduce the random block size, because if you are able to guess this one and guess this one and guess this last one, so the solution for this is just to randomize with random blocks, by which I mean that you can choose between a group size of 4 or group size of 8, in the case or group size of 2. So that's going to be a random allocation between 2, between 2, 4, and 6, for example. And same for the 3 groups. And this is going to be really, really more difficult to guess, right? So this is why people sometimes use random blocks for the randomization. Okay, so now I am hoping that you can understand the simple randomization. You can understand the block randomization of 1, block randomization of 2, and random blocks and the rationale behind all these things, right? So this is a block size of 4. It's another representation. So basically you have 4 groups here, right? For each group, you are going to have 36 different options here, like A, B, C, D, A, C, D, B, A, C, B, D, and so forth. So you see how difficult it's going to guess this, because the random program is going to choose between any of these 36 options. So it's going to be really difficult for groups, right? And in this way, it's going to be really, really extremely difficult to guess, right? So there are another way to, another sort of design, which is the allocation ratio. This is something that we see with some frequency as well. The allocation ratio it doesn't need to be 1 to 1. It could be 2 to 1, and there are strong reasons to do this. For example, to increase the statistical power of the study, or for example, because you are struggling to get the treatment patients because there are not many. So you may go for this technique for 2 to 1. So this is what happens in this case. So you have a block size of 6 with an allocation ratio of 1, and for 2 groups. So if the block size is of 6, so we've discussed the block size of 2, we discussed the block size of 4, and that is the block size of 6. So what happens in this case, that you have 20 different options if you go for that block size of 6 in a allocation ratio of 1, 1. And there is a way to design a allocation ratio of 2, 1 in this case. So 2, 1, that means that for every 2 patients allocated in A, 1 patient is going to be allocated in B, because the block size is of 6. So 4 patients are going to be in A, and 2 patients are going to be in B. And the sequence is going to be different in 15 different options. So you have 15 options to choose, not you, but the computer, right? So this is just to illustrate how difficult it's going to be to guess the last option. Okay.
Excuse me, Wilson. So
yes,
the
Clara.
allocation ratio, I was just about to ask you that, so you answered my question. So
Yeah.
the allocation ratio, if for instance, if you assign a 1-to-1 allocation ratio, that would try to balance each group, right? Because in some cases, if you use block randomization, groups can be imbalanced. Isn't that right?
I think you are correct, Clara. In that case, because this 1-to-1 is going to allocate here 3 patients in A, as you can see here, and 3 patients in B, plus 3 patients in A, 3 patients in B. So definitely it's going to be even distribution of the patients. So yes, the answer is yes.
But yes, I
Thank you
guess
for
we still have possibility to find some unbalance. I'm thinking is example 22 patients using a block randomization of 4 in the end, if you could show us again the slide with 20 patient and 20 patient. In this example, if we would have the 22 including, because our sample is 22, the next, because we need 6 blocks, and if the last block started with AA, we could have 12 in one group and 10, but again, it's not common, and we expected to have in a allocation 1-to-1 and using block randomization. In general, you will have exactly the same, but mathematically saying, is it possible to have some imbalance if the total number is not exactly the product, the mathematical perfect count for the block that you decide, but just a weird example.
Yes, exactly, Clara. I don't know if you understood the idea. Sorry, Karla. I don't know if you understand the idea. I think Clara was the one asking. Laura.
I guess was Clara.
Yeah, Clara.
So the problem would be with the last one, because if you go, say, for block size of 8, and then because there are 2 groups here, so the problem would be with the last allocation. So that may be a little bit uneven, the distribution of the participants, but it's not going to be as extreme as this example, which is the one I wanted to bring in my slide, because it might happen that only 6 patients are allocated in group B and 14 in group A, especially in small clinical trials. Okay, so
you might be lucky, right, with a simple randomization, and probably you just get 10 and 10, but there are slight chances that the imbalanced groups exist.
You are lucky, so you will have, but there is the possibility of having imbalance is high, especially in such a small sample size. Okay, and this is just an example of how stratified randomization will look like with a random permuted blocks. So imagine that this is the sample population, and then what is the stratification with? So it's basically this. When you are interested in including the same proportion of patients to hospital A, to hospital B, and to hospital C, this is just an example, obviously, and then you can include a second stratum. In this example, it's going to have 3 levels. So we call this stratum, and we call these levels. So the stratum 1 has 3 levels. In this case, in this example, is going to be the hospital. And the second stratum has 3 levels. So imagine that you're interested in patients with mild disease, moderate disease, and severe disease. So they are going to be allocated evenly in each group, as you can see here. And then once you stratify all these subgroups, so you can guarantee that the same amount of participants are going to have this the same severity of the disease, and all are evenly distributed among hospitals. And then once you do this, so you have to random the blocks, right? So in this example, and again, this is just an example. So you can, for example, you can choose between a random block of 4 or random group of 6, right? 4, 6, 4, 6, 4, 6, 4, 6, 4, 6. And then based on this, so you are going to be allocated either on treatment A or on treatment B. And these are going to be the random groups. This is how it works for the stratified randomization.
I must say,
yes.
Yeah, thank you, Wilson. This is so clear, so clear. I cannot thank you enough for showing this slide, I guess. I imagine Shobha, Flavia, my other colleagues that were students in previous years, sometimes it seems not really complex when you're reading and understanding advantage and disadvantage, but seeing the example, it's not easy, it's complex, and all these things it's used to try to increase your internal validity and increase the reliability, I guess, of your result in the end. So thank you, Wilson. I guess that's my only word, but it's I am sure that my colleagues agree with me.
Yeah, it was great, Wilson. Thank you.
Yeah, thank you, Wilson. Always, you are always the best, for sure.
So
that's why I keep sending messages to the alumni that go to the office hours, because you're gonna learn a lot.
Yes, it is a nice opportunity for everyone to ask questions, and I don't know if this is clear. This is clear for Iada, Laura, Clara? Is that clear for you?
Yes. Yes, thank you very much. I have one tiny little question. If in the trial the researchers don't clarify the randomization method, should we assume that they used a simple randomization?
I think it's a bad practice, really. I think I mentioned that, for example, you're reading a clinical trial with including 30 participants, and you see in the table 1 that 15 participants went to the treatment A and 15 to the treatment B. So you should assume that they did one block randomization, but they don't disclose that. I'm not sure if this is because they think this is obvious, or maybe it's not included in the in the consort guidelines. It's not mandatory to describe the randomization, but I think it's not a good practice. I think you should disclose how you did the randomization, and particularly when you are going for adaptive randomization, you really need to disclose why.
Yeah, and I think, Wilson, also you can, you can look at the supplemental section. There could be something there. And if you have the time and you care to, you can call the PI or whoever that envelope is attached, whoever name is the envelope is attached. That's the contact person. You can email that person and find out more, especially if you're going to replicate the study, you want to know, more details. So
that's an interesting comment as well, because it may be related to this space problem with the journal as well, because sometimes they limit the space. In clinical research, the less the better. You don't have to extend all your description, because your paper is going to be a little bit boring, and you just need to describe the most important things to transmit the message to the readers.
Yes, and I guess Wilson's slides show us that, okay, I will add stratification because it's important. I will add the block randomization. I will do this and this and that. But we should understand that it's necessary, but we should know a priori that we are adding complexity, necessary complexity, but in general, it means money, funding, and it's related with feasibility. And so it's important to know. Sometimes I sometimes we say, oh, they use adaptive design, a fancy something, but in the end, they used it because it was necessary and they had money enough to do this. So it's interesting to see in this slide how complex could be only one step, which is the randomization process. So, and I guess it's really important to understand the allocation concealment concept. That means that the researchers will allocate the patient not based on not knowing which group they will participate. So it's really important. And blinding is another aspect. Blinding is the participant and research not knowing the drug that they will receive. Sometimes, I guess, as a student, I had this misconception and don't really understand the concept of if it's possible to have allocation concealment in an open label trial. Yes, it is. I think I don't know if someone has this doubt, but I just would like to clarify. Wilson, I guess we are not hearing you.
Okay, now you can hear me here. Now, it is just my very last slide. I don't want to take any more extra time for this meeting, but just slide for allocation concealment. And it's actually very easy to understand, but sometimes it is, some students are confused between those terms, and they are completely different. The randomization is a concept different to allocation concealment. So even if the randomization process is done in a right way, so you have to keep in mind that the allocation concealment is as important as the randomization. So in this slide, the allocation concealment is just this. So imagine that you have 10 patients, and then you look at this.
Wilson, we're not viewing your slide.
Oh, sorry. Okay.
Sorry, Karla, can we record? Do you mind? Sorry.
Now you can.
Yes,
So
I'm
yeah, just a couple of minutes to discuss this. So what you see here is the allocation concealment. There are 10 patients here, and you have absolutely no idea who is allocated to which group. So I have no idea the first patient who which group was allocated. The second, no idea. Right? So what happens if there is no allocation concealment? Imagine that this is the disclosure of the allocation, right? So you have the same 10 patients, and then you have A, B, A, B, A, B, 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 A. So what is the problem that the researcher knows the allocation? The problem is that he or she may know that the B group is the placebo, or the A group is the placebo. So if you have this information of the allocation concealment, and then you know that the next patient is going to be the A, so you just bring the 4 patients here to be allocated to A, and you leave the 3rd patient to be allocated in B. And same here. So the 6th patient is going to be allocated here to group B, and the 7th patient is going to be allocated to group A, because the researcher knows that this is going to be the placebo. So this is a huge problem when you know the allocation of the next patient. if this is happening, this is going to be a source of huge bias, okay? Because more patients, because the characteristics of the patients in treatment A are going to be so different from treatment B, and there is no way to solve this out. And there are basically three strategies to do the allocation concealment. You may have read this in this week. So the first one is the SNOS, what we call this SNOS, which is sequentially number opaque sealed envelopes. Or you can go for sequentially number identical drug containers, or the central allocation, which is common nowadays via phone, website, or via the hospital pharmacy. It's very easy to get the concept. I hope it's clear.
Thank you so much, Wilson.
Thank you.
Thank you all. Again, we have a wonderful office hour. This topic's really important to understand. Sometimes could be easy reading or some more complex, but we hope that you enjoyed. And I will stop